All right, we are going to transition from the big world to back to our practices in primary care. And I want to introduce Dr. Parisa Kaviany, who is going to talk to us about something we deal with all the time. So here for an update about what's in your asthma toolkit, or what should be in your asthma toolkit.
All right. Hi, everyone. It's great to be here. I love seeing so many familiar faces, and I appreciate the opportunity. One of the reasons I went into pulmonary was because I love asthma, and one of the things I love about asthma is that we see it in so many different aspects of pediatrics care. So we've got like emergency room physicians taking care of patients with asthma. Obviously, in your clinics, you see lots of patients with asthma. Allergists take care of asthma. ICU doctors do it. Hospitalists do it. It's like a wonderful opportunity for collaboration for all of us in the field. In terms of our objectives for today, two things I want to focus on: apply some practical strategies to improve our access for our patients to common asthma medications, and then talk a little bit about asthma action plans, especially with the introduction of smart therapy to our asthma toolkit. Through Children's, we have something called the Asthma Registry, and it helps us to track patients with asthma who interface with our hospital and our clinics. And I know we've got more than this when we combine our patients that are in DC, Maryland, Virginia with asthma. But when we look at our Asthma Registry, which typically focuses on patients accessing care within DC, we see about 20,000 children with asthma. In 2024, there were about 3,300 visits for kids with asthma. And in 2024, we had almost 1,000 hospitalizations for asthma. And so that's about 5% of the patients in our registry were hospitalized for asthma. I know that you guys all take care of patients with asthma. So just so that we can get a sense of how we're all impacted, raise your hand if you've done a routine asthma clinic in the past month, and keep your hand up. How about if you saw a patient for an asthma exacerbation in the past month? And if you had a patient that was in the ER in the past month for asthma? And so if everyone had left their hands up, we really would have seen, I think, every hand in the audience. Just at Children's National in the month of April, we had 350 ED visits for asthma, to give you a sense. So obviously, we're all here and we're all doing our best. There's just a lot of kids with asthma. A little review of our asthma medications. So we all use albuterol as our short-acting beta agonist in this country. We've got long-acting beta agonists, which are never used on their own. We've got inhaled corticosteroids, and in terms of what we commonly have on our toolkit, we often use fluticasone. We'll use mometasone, which is Asthmanex, beclomethasone, which is Qvar. We've got a slight uptake in our use of ICS-LABAs with smart therapy. So those are combined inhaled corticosteroids with long-acting beta agonists. Commonly, we see formulations that have got formoterol and budesonide, and those go by the brand names of Breyna or Symbicort, or sometimes just generic budesonide formoterol. You may also see mometasone formoterol, and that commonly goes by the brand name of Dulera. And then we've got leukotriene receptor antagonists. The only one on the market for us right now is Montelukast or Singulair. And then a LAMA, which is a long-acting muscarinic antagonist, and the only one on the market for pediatric asthma is tiotropium, or goes by the name of Spiriva. A little blurb about Montelukast. I don't think we talked about this much last year, and I think we have seen it commonly used in practice, and these are some of the evidence-based uses of Montelukast. So it can be beneficial for short-term management of mild obstructive sleep apnea. It can be effective in controlling asthma symptoms, but ICS is considered superior. And then there is a role for use of Montelukast in exercise-induced symptoms, but studies have not demonstrated that it's superior to use of pre-activity albuterol. But that being said, I still feel like it's used a fair amount. I see plenty of patients who are on it. And last January, I don't know if you guys saw this New York Times article about the FDA warning about montelukast, which the black box warning has actually been on since 2020. But there were some serious manifestations of the side effects of montelukast that a select number of children experienced. And with that, I've had a lot more families ask about it. And so I just thought it was worth talking about in this forum too. The common side effects that are reported in younger children tend to be sleep disturbances, really vivid nightmares. I had like a 2.5-year-old that said to the parent, they were seeing people in their room at nighttime. And that was one of the reasons why I stopped the medication for that patient. And then in adolescence, there's increased feelings of anxiety or depression. And so usually if I'm meeting a child that's got anxiety or depression or ADHD, I try to avoid this altogether and utilize higher doses of inhaled corticosteroids or ICS/LABA. But I'm sure these are all things that you guys have seen in your practice as well. So SMART is kind of like the hot topic. I myself think through who is the right patient to use this for. I know when the NHLBI guidelines came out in 2020, there was kind of this feeling like, gosh, we have to put everybody on it. Is this the only thing that we can do? And I hope we can all share in this that SMART therapy is not for everyone. It doesn't have to be for every single patient that you see with asthma, but there are some patients that it would be reasonable for. So when we look at the guidelines that have been put forth, our appropriate candidates according to NHLBI guidelines are ages 4 and older. I will say that the international guidelines, the GINA guidelines, say 5 and older. So a little bit of variation there. But it's for those who have moderate to severe persistent asthma that are not well controlled on a low or medium dose inhaled corticosteroid. Anyone that's had a severe exacerbation in the past year, which can include any child that's been admitted to the hospital, or if you've got a patient that's uncontrolled when they're using an ICS/LABA just twice a day as maintenance and not throwing in those as needed doses. The recommended formulation is anything that's got formoterol as the long-acting beta agonist. And that's because formoterol is long-acting and it's fast-acting. And so it can replace albuterol as that rescue dose. For us, that would be generic budesonide formoterol, Breyna, or Symbicort. Initially, there was a lot more rhetoric about using Dulera because it's got formoterol in it. But when we look at the studies that were done, none of them were done with Dulera. And I personally have shifted away from using Dulera for SMART therapy, not because it's unsafe or that I've had a bad experience, but when I am trying to do a prior authorization and ask for a medication that's non-formulary, I can cite a study or the guidelines themselves that were only done with the formulation that is budesonide formoterol and get approval that way. So just a little review, and for anyone that attended last year, I know that we talked about this in a lot more detail, but for SMART therapy for the younger children, the formulation that's recommended is the lower dose, that's 80-4.5 micrograms. And your maintenance dose can be anywhere from 1 puff daily to 2 puffs BID. And you can titrate that based on how uncontrolled your patient is. And then what's important to note is that your daily max in this younger age group is 8 puffs per day. And that might affect how you choose to divide up your doses. If you've got a patient that's constantly using a short-acting beta agonist, you might say, okay, I'm going to put them on the 2 puffs BID, which means they'll use 4 puffs a day, and they've only got 4 extra ones to use throughout the day. And you may have a patient that's much better controlled after a few months, and you want to step them down, and you could step them down to 1 puff BID, for example, and give them more of those PRN doses available. Very similar approach, just in the older group, you can use the higher dose formulation, which is Symbicort or budesonide formoterol 160-4.5. And this is a little bit easier to remember because ages 12 and up, max dose is 12 puffs, so 12 and 12. It's a little bit easier to remember, but same idea. You can use anything from 1 puff daily to 2 puffs twice daily, depending on what level of control they need. And then all the leftover puffs can be done for as needed. Obviously, with a group this big, it's a little bit harder to have some engagement, but we'll walk through a case together and we can think through this together. So if you've got an 11-year-old that was recently admitted to the hospital for status asthmaticus and had been using a low-dose inhaled corticosteroid twice a day, and yet ended up with a severe exacerbation, you may consider changing this child to SMART therapy. And if you were to do that, you could start with, in the green zone, having 1 puff of budesonide formoterol at the age-appropriate 80-4.5 microgram dose twice a day. In the yellow zone, you could give them the guidance of using 1 to 2 puffs of the same medication as needed, noting that the max daily dose would be 8 puffs. I typically like to characterize or qualify the yellow zone by saying if they are needing more than 4 puffs in 1 hour, then they should stop using the budesonide formoterol rescue and take 4 puffs of albuterol. And if there's no improvement, then shift to the red zone. The reason for this being is that there's a theoretical risk of overdoing it with the long-acting beta agonist and saturating your receptors. And when we look at the recommendations that have been put forth by other children's hospitals across the country, everyone's sort of settling out at this 4 puff max in a 1 hour time period. And I like to give kids a chance of taking that albuterol to see if that relieves their symptoms and then being able to get to every 4 hours. Because there's going to be, like we said at the very beginning, SMART's not for everyone. So this might not work for some of your patients. You might prescribe this and they'll say, I didn't get any relief, so I want to go back to using my albuterol, which is 100% fine. For the red zone, I personally like to use albuterol because it buys me a little bit more time. The guidelines will say you can take 1 puff of budesonide formoterol every 1 to 3 minutes for a maximum of 6 puffs. And that only buys you 18 minutes. Whereas if you do your regular 6 puffs every 20 minutes in the red zone, repeated 3 times, that buys you an hour. And I feel like that's more realistic in terms of getting patients to a higher level of care. This is something that we sort of talked about within our group, and there might be different conclusions that other folks reach, but this is kind of what's been practical and has worked for us. I know that in terms of the asthma action plans that folks have, they, depending on what county you're in, your asthma action plan might look a little different. Some counties have filled in the medications, which is like really awesome because you only have to check a box, but then budesonide formoterol is not on there. So what do we do? And this isn't going to apply for everyone, but I just took the asthma action plan that was on the Montgomery County website. And I see here, like in the green zone, they let you write in your medication. So you can put in budesonide formoterol as the controller. You're able to put in what the maintenance dose is. And then you've got this exercise-induced dose or pre-activity exercise albuterol. But you can cross that out and put in your budesonide formoterol 1 puff before activity. The one thing I'll say is that typically for children who are using an ICS LABA, they don't need that pre-activity as much. And I've noticed that you end up not needing this after changing therapy, but I always start with this if that's something that they've had. In terms of our yellow zone, again, we're not going to find our medication of choice, but we write that in and we say you can use 1 puff as needed, and you put your not to exceed whatever number that might be. And the other section is where I put that guidance of if this isn't working, then use the albuterol. One thing that we are sort of working on is this yellow zone previously used to tell you, okay, do 4 puffs every 4 hours. If the kid's coming back sooner, what do you do? The guidance with SMART has been use 1 to 2 puffs as needed, and it only kind of maxes out in that 1 hour time period. So whether you put 1 puff or 2 puffs, I think is more dependent on what your daily dose is. Because if you're using 2 puffs twice a day and you've only got 4 extra to deal with, you may want to be a little bit stingy with how many puffs you put here so that they don't max out super quickly in the nurse's office at school. So it does require thinking a little bit more nuanced about what your patient needs rather than kind of doing the same thing for every single patient. And then for the red zone, like I said, I like to stick with albuterol there, but if you wanted to, you could put budesonide formoterol. This is a quick reference sheet, and I think everyone gets the slides. So this is something that I just have like saved on my desktop, which talks about how we do the green zone, the yellow zone, and the red zone, and gives you the options for whether you want to use albuterol or budesonide formoterol in the red zone. So as if like prescribing it wasn't hard enough, we can't actually get it, right? And so these are a couple of tips that I have found to be helpful. So I have like a dot phrase that I have saved that I drop into a note that just references the guidelines. It's one sentence. If you are trying to do this for a child that's 6 and older, you get the luxury of citing 2 guidelines. But if you're trying to do it for someone who's 5 and older, you only get 1, but it still works. In the note to pharmacy, when you're doing your e-prescription, the same way we used to write for albuterol, dispense 2, 1 for home, 1 for school, you do have to ask them to dispense 3, 2 for home, 1 for school for implementation of SMART. Because otherwise the pharmacist is going to think you made a mistake, or at least this is what's happened to me. I get a call from the pharmacist. Did you make a mistake? Did you mean to put 1? So you save yourself a phone call this way. And then in the prescription, you have to include the as needed puffs as well, because that's what's going to get the justification for insurance to give you 3. And again, we'll save you a phone call from the pharmacist of why you need so many inhalers. Prior to this, I wasn't like a cover my meds person, but now I am. And it's a lot easier than it seems. You can either sign up yourselves or you can have a proxy from your office sign up. And that way they affiliate with you as the provider. So if there's ever a prior authorization that's triggered at the pharmacy, you or your proxy will get that notification via email. This is all like anecdotally, but I prefer doing an electronic prior authorization because then I can attach my clinic note, which has got a lot more information in it. It also lets me like copy and paste things into the justification reason, which I've got saved in a Word document. These are all things that make the process a little less painful. And then making sure like in your assessment, you've got the reason why they're uncontrolled and just put how many courses of steroids, ER visits, anything that justifies that. And then this is like the one sentence that I have that I drop into every note. According to the NHLBI 2020 focus updates for asthma and the GINA 2025 asthma guidelines, the next step would be use of ICS formoterol MDI for single maintenance and rescue therapy. It doesn't work every single time. There are some insurance companies that require a little bit more information. They may deny it, and then you have to do a peer-to-peer. But I would say for the most part, this has worked relatively well in terms of not getting too much paperwork handed back. This is what the page might look like on Cover My Meds, the pharmacy that says that you've been rejected, and you click this little button that says continue prior auth. And then you have to have the patient's like name, address, insurance information in there, which sometimes auto-populates if the pharmacy starts it, which is great. And then under this prior authorization request evaluation questions, they will ask you a couple questions. They'll have you put an ICD-10 code, which usually is moderate or severe persistent asthma. And then you get to upload a file. And I usually just include my clinic note in that. And then it goes through. I wanted to share with you guys some patient information sheets that we just got up on the website in time for FOP. So I'm pretty excited about this. So they're available in English and in Spanish, and it just explains what SMART therapy is to families. You guys can print these from our Impact DC website. It explains what SMART is, why do we use it, how does it work, It explains that your maintenance dose is going to vary depending on what your doctor prescribes. And it's got these dose maxes of the 8 puffs and the 12 puffs. So we've got one that's for ages 5 to 11 years and one that's for ages 12 and up. And use this QR code. It should take you right to the Impact DC website. But if you're going on it from your computer, you can just go to Impact DC, go to Family Resources, and it'll be available there. And then what we are hoping to finalize this summer in time for the fall rush is a sheet that you can attach to your asthma action plan for school nurses, which explains smart therapy to school nurses with a little bit of language about the school nurse or tech or whomever is administering the medication should relay back to the family at the end of the day how many puffs were used, so the family knows where they're at with hitting their max. And hopefully that'll be live soon. And that's it. Thank you guys so much for your time. Sure. Yeah. Brina, yeah. Right. This whole thing takes an hour and a half. And we don't have that. And then I wanted your thoughts on yes. In it. Right. So when I can't get fluticasone and the child is not able to do technique for QVAR, Asthmanex is wonderful. Asthmanex generic is mometasone. And generally, I have been successful in getting either fluticasone or Asthmanex. Asthmanex comes in 3 tiers, so 50, 100, and 200, which can parallel your fluticasone 44, 110, and 220. So if you're having trouble with either one, that would be my go-to. And I know that the process is cumbersome for sure. Doing it electronically saves a little bit of time, and then you really can kind of force the hand of the insurance to give you either fluticasone or Asthmanex if you've got a child that is 7 years of age or younger, because they are not able to do the breath hold technique. And insurance companies have gotten more used to hearing this. And so if that's your justification that they can't do the technique for the dry powder inhaler, I've gotten approval that way. And then the questions about the Air Supra, which has got budesonide and albuterol in it. So part of the NHLBI 2020 guidelines was use of concomitant use of an ICS and a short-acting beta agonist, which would be this combo inhaler. But studies have shown that simultaneous use of an ICS plus a SABA when sick is successful only in the age group of the 5 to 11 years with mild persistent asthma. And that means they don't have to use anything when they're well, but when they're sick, they could use this Air Supra or some combination of budesonide or an ICS plus a short-acting beta agonist every 4 hours when they're sick in a way to mitigate the need for oral corticosteroids. That usage of ICS plus SABA hasn't been proven to be successful in other age groups. So if you've got that tight age group that's got mild persistent asthma, then I think that's a reasonable choice. But not everyone's going to fit that description. Yeah.
Hi, I have 2 questions. So one is when you talked about, Oh, sorry. I'm Rachel Dodge. How are you? I'm from Dundalk Pediatrics and also the president of the Maryland AAP, if anyone wants to talk to me about that. So the Montelukast, so you talked about that. And I mean, that's always been pushed for kids with like allergies, if they have allergic rhinitis. And I always feel like that's where, so I just wanted to kind of, because you didn't really say something about that. So I wanted to get your thoughts on that. And then the second question I have, has anyone thought about creating some standard asthma action plans for different levels of kids? I mean, I know that I feel like there's the most common medications and the most common things. I mean, when we start getting to these moderate, persistent, severe, persistent kids, it gets more complicated, right? But 90% of what we deal with in outpatient pediatrics before we're asking for you guys' help is, mild, persistent, maybe some moderate persistence, right? It starts getting severe. And what we don't have time to do is figure out that whole asthma action plan and all of those details. Like she said, it takes forever to do this. And then if I sit and I take the time to write up a whole asthma action plan, and then the insurance company says, no, you can't use that. Now I have to take the time to write a new asthma action plan, right? I mean, these are major problems. If I could just go somewhere and print out the typical asthma action plan for a moderate, persistent kid, depending on age, and a mild persistent depending on age, that would make my life so much easier.
I'll start with that. I fully agree. And that was actually a conversation that I had with Dr. Fox earlier. The problem is what the schools are accepting. So in the District of Columbia, we worked with the Department of Health and they approved for us this kind of generic asthma action plan that we're able to do electronically, no signature other than your electronic signature. And that's been trickled into the DCPS. But the problem is that your states are much larger when we're talking about Maryland and Virginia, and finding plans that work for all the schools has been hard. So I think maybe on an AAP level, this is something that we could advocate for. Yeah. And then quick bit about the Montelukast. If the kid just has allergies, I prefer using an antihistamine because I think we're getting to the root of that problem better. And if the kid's got allergies and asthma, I think an ICS is superior to Montelukast, as has been shown by the studies. So I would just put them on an ICS and an antihistamine if we're concerned about side effects. Thank you, guys.